questions with the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Tuesday, March 18, 2014. I would now like to turn the conference over to Ricky Baum. Please go ahead.
Thank you, Carlos. Hello, everyone. My name is Ricky Baum, and I'm the Policy Analyst at the National Abandoned Infants Assistance Resource Center, located at the University of California at Berkeley. The center is funded by the Federal Department of Health and Human Services Children's Bureau. Our mission is to enhance the quality of health and social services delivered to children and families affected by substance abuse and/or HIV. We do this by providing quality training, information, and resources to professionals like yourselves who work directly with these families. Today we are hosting the second in our 2014 webinar series. Our presenter is Dr. Mary Dozier, who will discuss interventions to support children in high-risk families, focusing on the attachment and biobehavioral catch-up, or ABC, techniques that she's developed from her years of research. Professor Dozier is the Amy E. DuPont Chair of Child Development at the University of Delaware and the principal investigator of the school's Infant Caregiver Project. She is a renowned national expert on the development of young neglected children and young children in foster care. Her award-winning and widely published work has been supported by the National Institute of Mental Health continuously since 1989, and we are indeed fortunate to have her share her considerable expertise with us today. Before we begin, I want to remind you again that you may ask questions via the chat feature, which you should see in the lower left portion of your screen. We will pause once during the presentation and again at the end for questions, but do please feel free to chat questions in at any point. We're going to try to answer as many as we can in the order received, and we will email responses to any that we do not have time to address on today's call. And with that, I'm going to turn our virtual podium over to Mary.
Thank you so very much, Ricky. I'm delighted to be presenting as part of the AIA webinar series, and I welcome all of you there in the audience. Over the last 20 years in our lab, we've been studying the development of young children who have experienced adversity. We've identified several key issues that such children often have trouble with, and we've developed an intervention, attachment and biobehavioral catch-up, that targets these issues. Today I'm going to tell you about the issues we've targeted and about the intervention we've developed, as well as some of the evidence that the intervention is effective. I look forward to hearing your questions both at the intermediate point and at the end of the talk. Babies are born dependent on their caregivers. They're dependent on caregivers for virtually everything, for help in regulating temperature, help in regulating their neuroendocrine system, which I'm going to come back to describe later, for protection from infection, protection from danger, and so forth. And so when there is a problem in this caregiving system, nothing could be more threatening to the child. I would suggest that even the lack of food and water is not as threatening as the lack of a caregiver. So when there are caregiving failures, it's not surprising that we see effects on health and mental health. At the extreme, the effects of severe deprivation are seen in health outcomes, things like stunted growth and immune system problems. We also see the effects of neglect and abuse and other adversity on mental health outcomes, such as problems with emotion regulation, things like depression and anxiety among when children become older, and in problems with behavior regulation, things like problems with conduct disorders and substance abuse, for example. To address these problems in coping, we've developed this intervention, attachment and biobehavioral catch-up, which I'll refer to as ABC. This is a 10-session intervention that's conducted in families' homes. And we have families, parents and children there for the sessions. When I give this talk in person this slide is accompanied by a picture of a parent coach, that's what we call the clinician, who is surrounded by a mother, a grandmother, and 6 children of various ages, all sitting on the sofa together. It's important to us that the intervention take place in the home and that everybody be there, because what we want is we want to change parents' behavior in the environment in which they live. We think at the other extreme that changing parents' home in an office or clinic or in a classroom is not likely to result in generalized change. So we want to change what they're doing, and you'll hear this throughout the talk today. And I'm not suggesting that other interventions can't have effects through work in the office or clinic, but I think that it's easiest to have the most direct, generalizable effect in the home with everybody there. This is a model of the intervention and its intended effects. On the left, you see ABC intervention. That, again, is the acronym for Attachment and Biobehavioral Catch-up. And under that, in-the-moment comments. I'll talk about the in-the-moment comments later in a lot of detail. We see these comments that parent coaches make in response to parent behaviors as the critical active ingredient in the intervention. And what we seek to affect directly is enhanced parenting. So what we want to see changes in nurturance, following the child's lead, and non-frightening behavior. And I'll be going over each of these parenting behaviors that we target in this next 30 minutes or so. And then we expect that changing these parent behaviors is going to lead to changes in the child's attachment quality and early changes in self-regulation. And then there are further behaviors out here that I won't be talking about as much that are longer, more distal outcomes. Now, this next slide presents these same 3 intervention targets, but in a slightly different way. I'm going to talk about each of these targets in turn. I first am going to talk about this issue of children pushing their caregivers away. Now, one of the challenges to providing nurturing care to children who have experienced early adversity is that children who have experienced adversity often behave in ways that push their caregivers away, and it makes it difficult for the caregiver to respond in a nurturing way. In case you're not familiar with the strain situation, this is the procedure that's typically used to assess attachment among infants and young children. Children are separated from their parent twice in the strain situation and then reunited. What we and other people who code the strain situation pay attention to is the child's reaction to the mom or the parent upon return. It doesn't matter so much whether the child cries a lot or not during the separation, but what matters is how the child responds to the parent upon reunion. That tells us about the child's expectations about what the parent will do when the child is distressed. So what I'd like for you to do is picture a child who's been separated from his mother in a strained situation. He's in the arms of a stranger, but he's very upset and crying hard. When his mom returns, he gets down from the stranger, goes to his mom, and puts his arms straight up, and then he's picked up by his mom, and he settles very quickly and quietly in her arms. This is the prototype of a secure infant. Now, what I'd like for you to do is think about your own reactions if this child were to respond this way to you. I think one of the striking things is that the parent feels such a sense of calm and even efficacy in this situation. She knows that she can soothe this child. Now picture something a bit different. When the mother returns this time, the child looks up and then looks sharply down at the toys and doesn't respond to the mom. The mom tries to engage the child, but in this case, the child will not engage with the parent. Again, think if you're the mother or the father of this child. This is an actual video that I'm describing to you, and on this particular video, you can hear the mother say, "You don't care. You don't care about mommy." So I think that really lets you know how powerfully the child's behavior can have an effect on the parent. In this case, the child has learned not to turn to the mom for support when distressed. And really, a problem here, though, is that so the mom may have not very reliable in terms of the child's distress, but then the child's behavior is going to continue to elicit that kind of behavior from the parent. Even if the parent changed, for example, through our intervention, or if the parent was a different parent, if it was a foster parent instead of a birth parent, this child would have become good at eliciting behavior that sort of failed to elicit nurturance. We conducted a study of young children as they were first placed into foster care, and what we found is that children's behaviors very powerfully elicited complementary behaviors from their parents. By complementary, I mean when children showed secure behaviors, their parents provided nurturance. But when children acted as if they didn't need their parents acted as if they weren't needed. In this case, this was with, as I said, with foster children. Many infants, especially those placed after about a year of age, behaved in ways that suggested to parents that they weren't needed, or as if the parents couldn't soothe the child. They remained fussy and irritable, resistant, if you know the language of the strained situation. And we found, coming back to the slide in front of you, we found through contingency analyses that parents responded in kind to children. Again, that is, secure infant behavior elicited nurturing parent behavior. Avoidant infant behavior elicited he doesn't need me kind of behavior from the parent. And resistant infant behavior elicited angry behavior from the parent. It was surprising to us just how powerful children's behaviors were in eliciting complementary behaviors. We don't think of infants and young children having that sort of power, but the infants in this case were in fact leading the dance. Now, I'd like for you to think too here, and this may not seem quite as odd, think of an adult relationship. For example, a colleague who may have experienced a recent death in her family. If you were to go up to your colleague and say, "I'm so sorry about your grandmother's death," and she says, "Hey, I'm over it," most people's tendency, maybe not us because we're a bunch of therapists and clinicians, but most people's inclination is to back off and not provide more support. That's the phenomenon we're really talking about here. I think what's surprising is that it's infants that are doing this, infants that are having this power over their in this case, their foster moms. So when infants have experienced early adversity, they're likely to behave in ways that push caregivers away. And what we know from our work in other contexts is that nurturing care is just critical for babies who have experienced adversity. It's critical for them to have nurturing care if they are to develop organized attachments. So our first intervention component is that this child needs you, even though he or she may not appear to need you. We want parents to provide nurturance, even though the infant may not elicit it, even though it may not be what comes naturally to the parent. Now think of ways that parents may not provide nurturance. So go through in your head the various ways that parents may not provide nurturance. My bet is you'll think of some categories that I haven't thought of here. So I think one of them is by distraction. The child hurts himself and the mom says, "Oh, look at the butterfly. Look inside." Another is by fussing at the child. "You shouldn't have been standing on that chair. No wonder you hurt yourself." Another is by trying to toughen the child up. For example, saying, "Hop up, you're okay," or "You're a big boy," or "You're a big soldier, you're a brave soldier, soldiers don't cry," or whatever. And another is by ignoring the child. Each of these ways of failing to provide nurturance gives the message to the child that he or she shouldn't turn to the parent when hurt, when frightened, etc. And so what we want parents to do is to think of all of those possibilities, but then recognize that this child who has experienced adversity especially needs nurturing care. Even if he doesn't look like he needs nurturing care, this child needs nurturing care. Now, this is the easiest thing we do in our intervention because it sort of sounds, as the way we present it, as if it's all about the child and not so much about the parent. It's the easiest thing we do, and we do it first because it's the easiest thing. Now, with all of our intervention components, we implement them in three ways. First, we have a manualized curriculum. We raise issues through the manual, but it is critical that this not be what gets most of the attention of the parent coach or of the parent. Second, we do some use of video feedback. brief clips of parents that highlight things, often 5-second clips, to demonstrate concepts, demonstrate their strengths, and then sometimes to demonstrate things they might work on. And then third, and what we think is most important, is we provide in-the-moment feedback to parents. Anytime there is an opportunity for a parent to behave in a nurturing way or to follow her child's lead, this is a trigger for a parent-coach comment. So I want to describe an example of this with regard to this first intervention component. Keep in mind the first intervention component is providing nurturance to the child. A mom, her son, and the parent coach are on the porch of the mother's house. The child falls down and fusses. The mom hesitates, and then she moves over to pick up the child, and she's saying, this is the first time he's ever laid on the floor like that. And you get the feeling she's not very comfortable picking him up, and she might put him down. The parent coach says, yes, pick him right up. That's so good for him when you pick him up. It lets him know that you're there for him. Then the child kind of settles and gets playful again, and the mom puts the child down, and he jumps to his feet with a big smile, and the parent coach says, that's all he needed was for you to let him know he was there. So that's an example of an in-the-moment comment, and I will come back to those in more detail as we go along. So that was our first intervention component. The second is that children are often dysregulated biologically and behaviorally. There are a number of studies with both humans and with non-human primates and other species that have demonstrated that adversity can lead to biological dysregulation. One of the ways this dysregulation is seen is through the production of a hormone, cortisol. Cortisol is produced as an end product of the HPA axis, and HPA refers to the hypothalamus pituitary adrenal axis. Now, cortisol has two independent functions. One is mounting a stress response. For example, the most reliable stressor for adults is public speaking. So if you think of the last time you had to speak in front of an audience, odds are your hypothalamus sent a message to the pituitary, which sent a message to the adrenal to release cortisol. And this is the sort of gets you prepared for the stressor. Odds are my cortisol levels are higher now than usual. A second function is the maintenance of a diurnal function. We have a number of systems that help us function as diurnal creatures and help other species that are nocturnal creatures function as nocturnal creatures. And it's useful because it helps us to be up when other members of our species are up. And this is, for example, a reason that you experience trouble adjusting when going across many time zones is that your body is on a 24-hour cycle. Now, we're able to look at cortisol non-invasively because you can look at this with saliva. You can put a little Kool-Aid on a swab, and as you can see here, children like that. And going back to this diurnal cycle, what you can see here is what most of what it's going to look like for most of us across the day in terms of our cortisol production. Don't worry here about what's on the y-axis, but what you see here is a high morning value for cortisol. It peaks about 30 minutes post-wake-up and then comes down across the day to near zero levels here at night. And what it's important to think of, it's not the case that you are more stressed here in the morning. It's rather this is an independent function of how cortisol works in the body. This helps us, again, get up. It helps us to metabolize or reflects the metabolizing of glucose in the morning, and then being able to go to bed at night to calm down and so forth at night. Now, I show you this with the arrows because this, where we try to look at this, is the time where it's the most robust effect, and that is we try to look at as close to wake up as we can and as close to bedtime. These are noisier times here in the middle of the day. And if you look at this is what low-risk children show, is a high morning value and a low evening value, a nice steep slope across the day. kids living with their low-risk parents, biologically intact dyads. What you see among foster children, though, and this is a study that we conducted several years ago, is you see a flatter slope. Lower morning values, a flatter slope. And then among children living with their neglecting birth parents, the flattest slope of all. So still lower morning values and a very flat slope. So this suggests to us that adversity is really leading to children having problems regulating their neuroendocrine system in this case. We also see evidence of behavioral dysregulation among children who have experienced early adversity. For example, if you see a child running around the room and really unable to control his behavior, that's a good indication that that child is behaviorally dysregulated. Also, we see problems with regulating emotion among children who have experienced early adversity. So we've got good evidence that children who have experienced adversity have trouble regulating behavior, emotions, and physiology. And so we wanted to intervene in ways that help children regulate their behavior, physiology, and emotions. And whereas with the first intervention component, it was clear, it was easy to come up with how one would intervene, this one was a little tougher, it was less intuitive. How do you help children develop their self-regulation? And we looked at the literature pretty carefully, and what we came up with is that when parents are more responsive to their children, we found that children develop better regulatory capabilities. There were several studies out at the time, Sibel Raver's study, for example. Since the time that we ran into this issue, a number of others have made the same kind of connections. For example, Jack Schoenkoff refers to these as serve and return interactions, whereby the child serves and the parent returns the serve. So we help parents to follow their child's lead as a way to enhance children's regulatory strategies. Now I want you to think of ways that the parent might not follow a child's lead. So go through in your head and think of all the possibilities of the way a parent might not follow a child's lead. Again, I think you'll probably come up with ones that I haven't come up with, but one is to be very controlling and to say to the child, no, this is the way to do it. Another that's kind of related is to be kind of teachy, and that is, hand me the red one, or what color is that, or what shape is that, or whatever. And another is to be passive and uninterested. So what we know is that we want to help parents follow the child's lead as a way to enhance children's regulatory capabilities. And we want to do it, we've developed manualized content that is directed toward this. But again, what we think is the most important are these in-the-moment comments. And so here's an example of a parent coach making an in-the-moment comment regarding following the lead. The mother and the child are reading a book, and the instructions have been to follow the child's lead. No matter what he does, you do what he does. If he puts the book on his head, you put the book on your head, and so forth. Oh, sorry, it's the grandmom and the child. And the grandmom, though, is being very teachy despite these instructions. She says, what color is that? She says, no, that's a frog, etc. Then the child says, it's a circle. And the grandmom says, a circle? And the parent coach jumps in at that moment. That's the first sort of inkling of the grandmom following his lead. She says, that's great. He said it's a circle, and you said it's a circle. It doesn't matter whether he calls it a ladybug or not. It just matters that you're following his lead. And then the grandmom looked at the child looked, and they both got surprised expressions on their faces. And the parent coach says, and look how he looked up at you, and you looked right back at him. And then the amazing thing is that this kicks off a cascade of the grandmother following the child's lead. It's one of those exciting things to see in a session. The third issue that we target is frightening behavior. And parents behave in frightening ways for a variety of reasons. They behave this way to control behavior as a response to their own distress, and sometimes just because they're unaware that they're doing it. And when parents behave in frightening ways, though, it's very hard for children. Mary Main has talked about this as children experiencing an unsolvable dilemma under such circumstances. They need to depend upon their parent, but they fear their parent, and so they're sort of stuck. And this leads to a breakdown in attachment or a disorganized attachment. And it can be seen in several ways in the strained situation, the assessment of attachment that I referred to earlier. Whereas other children have a strategy for dealing with their parents when distressed. It may be a secure strategy in which they move to the parent and are comforted, or it might be an avoidance strategy in which they don't move to the parent, but instead keep some distance, or a resistance strategy that I haven't discussed. But in each of these cases, it's a strategy, and it's a strategy that maintains optimal proximity to their parent. But with children with disorganized attachments, they either don't have a strategy or their strategies break down. And this is seen in behaviors such as apprehension of the parent when the parent returns to the room following separation, in stilling or freezing. This is an odd sort of thing where a child just, in the case of freezing, they're actually defying gravity. They're holding their arms in an unnatural position for a set period of time. They might show contradictory attachment behaviors such as both reaching, crying, and yet falling on the floor. And disorganized attachments are more concerning to us than insecure attachments because they're most strongly predictive of later externalizing problems. And by externalizing problems, you probably know what I mean, but I mean things like getting in trouble in school, aggression, problems with peers, and problems with dissociative symptoms. And by that, what I mean is being spacey, being out of it, and so forth. In terms of disorganized attachment being associated with later externalizing problems, there's been a meta-analysis of the number of studies combined that has found a strong effect of disorganized attachment predicting externalizing behavior. There's less evidence, but there are a couple of studies that have looked at disorganized attachment predicting dissociative symptoms later. So this is something we really worry about. We worry when we see, when we're predicting disorganized attachment. And so we want to intervene in ways that make parents less likely to behave in frightening ways. And we do this by helping parents first become aware of behaviors that may be less threatening for them to acknowledge, things that may just be overstimulating or intrusive, things like tickling, playing with puppets in ways that scare the child, etc. And then we go on to think of behaviors that we call frankly frightening, things such as using a threatening voice, grabbing the child roughly, things like that. And what we do is we often show parents video clips first of times when they were not frightening but might have been given the conditions. For example, a time when the child was getting on the parent's nerves, but the parent held it together and wasn't frightening. And get them to think of how they were able to, the parent was able to keep it together then rather than be frightening. And then we show them a clip in which they were frightening. In all of these, we're trying to we're trying to help a parent feel strong while still able to look at their own vulnerabilities. So our intervention then targets these three things. The child pushes the caregiver away, but what we want is the caregiver to provide nurturance even though the child fails to elicit it, and even though it may not come naturally to the parent. And we think this will lead to a secure, organized attachment. Second, children are often dysregulated behaviorally and biologically, and we want parents to provide responsive care, to follow the child's lead. We expect this to lead to enhanced regulatory capabilities. And third, we know that parents sometimes are prone to behave in frightening ways, particularly if they live under high-risk, challenging conditions. And we want to help them to not behave in those ways, and we think that this will come back and help enhance children's regulatory capabilities and also help lead to a secure, organized attachment. So at this point, I'm ready to take questions or comments.
So we have a few questions for you, Mary. One of them is, would an example of a contradictory contradictory attachment strategy be when a baby cries and pulls away or arches back when mom attempts to pick up and respond?
That's a great question. And what I would say about that is more likely a resistant response than a disorganized attachment. I didn't go into resistant at all, but keep in mind, secure you got is the child can settle at some point. It may take the child a while to settle, but the child can use the mom and settle. An avoidant attachment is the child turning away from the mom. And a resistant attachment, which I didn't describe, and I apologize, is when the child needs the mom and sort of goes to the mom, but at the same time is showing fussy, irritable behavior. And this is a resistant attachment. It's interesting though, that a disorganized attachment is contradictory, and so what happened once this ABC, the secure, avoidant, resistant taxonomy had been developed for 15 years before Mary Main added on the disorganized attachment. And what was found when they added on disorganized is that a lot of the classifications of resistant attachment went into the disorganized, were subsumed by disorganized attachment once that was added. And so I think you've raised a very important point there, and that is that it's really sometimes resistant versus disorganized is hard to tell the difference between. But let's say a disorganized, sort of classic disorganized would be mom comes into the room and the child's crying, but the child just goes flat to the floor crying rather than going to the mom. That would be disorganized rather than resistant, even though the child is showing fussiness and clearly needing the mom. A child who would both turn away from the mom, but also, and here's the contradictory part that I think you asked about in your question, turns away from the mom, but turns away while crying. That would be a good example of both the resistant and the avoidant, both at the same time.
Thanks, Mary. We have a second question for you. How do you sell this intervention to a family? In other words, in what context do you end up working with the family?
Another great question, and what I would say is it just really depends. This isn't going to be useful for your purposes, but we've done a lot of these, as I'll be telling you, as part of randomized clinical trials where we've been able to pay parents for their participation, and that certainly makes it much easier. But sometimes we get into social systems. For example, we've worked with all the foster parents in Delaware as part of an agreement with the state of Delaware. And so every foster parent who has a 2 to 3 year old is enrolled in our intervention, either our one of two interventions. We're now disseminating this around the country and other parts of the world actually, and those places vary in terms of how they access parents. Sometimes parents are referred through child welfare systems, and it's part of what the services are that are going to be provided to the parent. Sometimes they get volunteers, and of course that's harder. What I would say, we become very valued by parents once this is a very much a strength-based intervention, and even within the first session, partly because of these in-the-moment comments, parents feel very respected and valued by the parent coach. So it becomes easier, but getting in the door is it just varies by wherever we are. And that's I don't know that I've answered your question very well, but it's really however you get parents in for services, high-risk parents in for services.
Okay, we have another question. When is it appropriate to teach with a child? For instance, when should a parent tell the child that is a ladybug? Or would saying, yes, it's a circle and a ladybug be ideal?
Well, what I would say is we are working very hard, and that too is a great question. we are doing our intervention also with parents who are adopting internationally. And that's a population of people who are very highly motivated. They're often highly educated, and they have children that they're worried about being behind educationally. So this is an issue that we run into, especially with, and people are often getting a lot of PT or occupational therapy. So they're getting a lot of help with teaching things. And so we're often saying you don't need to teach. What I would say is that what children need most who are dysregulated is that they need to feel heard and need to feel followed. And I'll give an example as well. But that the teaching part can actually get in the way of that is what my concern is, that taking it other ways can be problematic. Let me give an example first and then come back. If you think of your own something that you did this weekend that was really important to you and you're telling somebody and they correct you about it and they say, no, it really wasn't down to 30 degrees this weekend, it was only down to 34 degrees, then you feel not heard, even if they're listening to everything else. It's a little jarring. And what we're wanting to do is we're wanting to create a smooth interaction for the child, something that feels controllable and develops a sense of efficacy, being efficacious. So I think that, and I can think of another example too with nurturance, where somebody came up at a recent talk and said, after I nurture my child, can I then say you shouldn't be standing up on that step though? And I said, no, you can't. You can't do it even then, because you've then taken away the part that just feels comforting and nurturing. The next time the child is up on the step, you could say, be careful, honey. Remember what happened last time. But you don't want to disturb this feeling of being, you don't want to get anything else in the way of it. So I guess I would want to go for purity with following the lead and with nurturance.
Okay, thanks, Mary.
Can I give one more? Can I give one more example, or would you rather I didn't?
Well, I think in the interests of time,
okay.
I think if you can go with that one example, let's move on to a couple of the other questions. What's the age range of children for whom this intervention has been shown to be effective? Is there any indication this intervention could be useful for children in other age categories?
Well, we have intervened with children up to 2 years of age with the intervention that I've been talking about, and I'll be presenting evidence regarding the effectiveness of this. Then, as children get older, they were intervened with as babies, but then the intervention still has effects when they're 4 and 5 and 6. We have adapted the intervention now for 2 to 3 year olds, and we have. I'll show you one slide from that study. That's very much we're right in the middle of that study right now, but we do have attachment data for that. So I would say this is a baby intervention, and it can be used across a couple different populations: children adopted internationally, foster children, high-risk neglect children. But it's pretty much a baby intervention.
Okay, thank you. And one more question. So you're doing 10 sessions with foster parents. How do you incorporate these sessions with biological parents who do not have children in their home?
We do the intervention when they get their child back, is when we do it. So we don't do this in the abstract. We really think it's important to have the child there. I will say that we are now developing a mini version of this, along with Carol Schofer at the Youth Law Center in San Francisco. We've developed a mini version of this to help with visitation. So we do this with birth parents and foster parents in 5 visitation settings. So it's not really designed to change behavior so much. It's really designed to help birth parents not be feel so rejected by their children. It's designed to help birth parents feel more supported by foster parents, and it's designed to really help the child not have such an aversive
Okay, thank you. Two last questions, and then we'll have some time again at the end of the presentation. How do you work with parents to minimize frightening behavior, especially when the parent might have had a traumatic history herself and is acting frightened when she feels something triggering that trauma for her?
Great question, and that we do very directly. We do it, it sounds like somebody may be familiar with child-parent psychotherapy, and we do it in a much more abbreviated way than child-parent psychotherapy does. But we help parents to actually think of things from their past that may make them, that they may not be fully aware of, actually. And we do this both with regard to frightening behavior, but then we do it also with things that get in their way with following the lead and nurturance. So we ask parents to think of experiences from their own histories where somebody might have been frightening or might not have nurtured or whatever. And we actually try to access those, use those. Now, what I would say that's different from some interventions is we don't work through the trauma, but rather we try to get parents aware of whatever it is, the trauma, so that they can override that. And that's the way we approach this. Not that we will have the parent no longer be traumatized, no longer be stuck in some respects, but rather they will be able to recognize, oh, this is that thing, but what he needs right now is he needs me to not be frightening. He just needs me to pick him up and use my regular voice. That's what he needs right now. And so I'm going to override what the voice from the past, and I'm going to help just be calm and be available right now.
Okay, thank you. And final question for now. How does a therapist differentiate between behavioral dysfunction that's due to the adversity and the stress of a parent not giving the most nurturing behavior and ADD?
Well, that's interesting. I think that some ADD has its origins in parents being overstimulating and not helping children develop regulatory capabilities. I'm not suggesting that all of it is, but I think that there's some evidence from, example is a study by David Jacobitz, that overstimulating parents really overstimulate children and then children fail to learn regulation. Now there's lots of children that are in this group that are going to develop, no matter what we do, are going to develop attentional problems and problems with hyperactivity. But we can still help them control some of it by, I think, still developing better self-regulation is still what we strive for, even though there still are going to be problems. We're going to do what we can to sort of develop the child's capacities in that respect, regardless of what the child's endowment might be.
Okay, great. Thank you. And please keep your questions coming in through the chat function, and we'll address more of them at the conclusion of the presentation. Thanks, Mary. Keep going.
Okay, great. Okay, now I want to tell you about how we assess the effectiveness of the ABC intervention. We assessed the effectiveness in randomized clinical trials with both foster parents and with neglecting birth parents. As you know, randomized clinical trials are the gold standard for assessing effectiveness. Confounding variables become less likely a problem when participants are randomly assigned than when not. And you can determine causality in such studies in ways that you can't in just a pre-post design. Also a strength is that we used a control intervention that we're calling Developmental Education for Families, or DEF, that had the same number of sessions, is conducted in the home, same length of time, etc., that the ABC intervention did. The DEF, or Developmental Education for Families, focused on cognitive development, and it avoided any coverage of the issues of ABC. Although it's very expensive to implement a control intervention like this, because it's costing us as much to intervene with the control intervention as it does with the ABC, It's really important because families don't know whether they're receiving the experimental or the control intervention. And it's a much tougher test of an intervention's effectiveness than if we were to have used a waitlist control. I'll be presenting results from both of the randomized clinical trials, and both of these had this ABC. Families were randomly assigned to either the ABC group or to the DEF group. I'll present mostly the high-risk birth parent study results. We had 120 parents in most analyses, and I'll let you know when it was smaller than that, half in ABC, half in DEF. First, we assessed attachment in the strain situation, and you've had a good explanation of that already. And what we found is that the breakdown was significantly different for the ABC and for the DEF groups. I want to remind you, because I'm just so proud of this result, this is a 10-session intervention in parents' homes. And then we're assessing through the strain situation what the attachment looked like. And what you see here in this next slide is that ABC families, ABC infants, 32% of these children showed disorganized attachments. And in the DEF, 57% showed disorganized attachments. That's a really nice big change. I've sometimes been asked, aren't you unhappy with 32% still showing disorganized attachment? And I've thought that we would never improve beyond that because these children are living under such challenging conditions. But in any case, I think this is a wonderful finding. This is N of 120, so reasonable sample size and so forth. Now, I'm going to show you also preliminary results from this intervention with toddlers in foster care. And this is in the preschool strain situation, which is very similar to the infant strain situation, but disorganized attachment isn't seen. It's not seen often, and so I'm going to show you here security versus insecurity rather than disorganized attachment. And what's exciting here is that, as you can see, in the ABC group, 84% of the children show secure attachments, as contrasted with 44% in the DEF group. I had always said, my graduate students have laughed at me with the previous slide, I've always said we would never do better than those results. And in seeing these results, I've been shocked. And I think the reason for it is I think it's very hard to change attachment, especially through a 10-session intervention. Okay. Second, we wanted to look at whether we affected biological regulation through the intervention. And so we assessed cortisol at wake up and bedtime. And we're looking at this post-intervention only. Keep in mind, we didn't look at strain situation at pre-intervention, and the reason is because children are often too young at that point. And also the same is true for cortisol. So this is what the data that I showed you earlier, and I'm just showing you again because what I want to remind you of is that what we want to do is we want to change this flat line. We want to get these children showing not such a flat slope across the day, but rather higher morning values. And what we find is that the ABC group shows higher morning values and a steeper slope across the day than the DEF. DEF is showing a flatter slope. And this is at post-intervention, say a month or so post-intervention. And then we look when children are 4 years old. And what we see there is the same or even a stronger effect. And so 2+ years following the intervention, we're still getting ABC kids showing different biological regulation than the children in the DEF intervention. So a very exciting finding. One thing that I imagine you might ask about is, what about the bedtime values? Mornings are the more robust places to look for intervention effects. I would love to see these lines cross over and the ABC be lower, but the steep slope functioning value is where we would expect to see differences if we're effective. Next, we examine children's emotion expression in a challenging task. Now, if you think about an important developmental task for a toddler, it's often feeling like, by God, I can do this myself while still relying competently on your parent. And that's one reason why toddlers get so frustrated, is they want to do it themselves and they find that they're not able to rely well on their parent. So we gave children a task that we borrowed from the longitudinal project in Minnesota, Alan Strofe and his colleagues' task, in which we gave children a task that was too difficult for them to perform by themselves, something like a ball inside of a tube that they could only get out by using a particular tool. And what we were looking for is whether children's expression of negative emotion. And what we found is that children in the ABC group showed less anger towards their caregiver, and less negative affect than children in the DEF group. Now, we also looked at executive functioning. And executive functions refers to the management of cognitive processes, or what I call the boss of the brain. Things like decision-making, problem-solving, shifting rules. And I suggest that executive functioning is the most important thing that distinguishes children who get along in school from those who don't by the time they get to 5 or 6-year-old. Now, an example is that if a child can sit in his chair as a 5-year-old and work on kind of a boring worksheet, as opposed to jumping up and looking out the window, he's going to be okay, whether or not he knows his numbers, knows his letters, etc. So this executive functioning thing is just critical for getting along in school. And how we assess this is through a Phil Zalazzo test, a dimensional change card sort that I'm going to show you in these next couple of slides. We ask kids to first play the shape game. And here we ask them to put the rabbit in the rabbit pile. And so that would be, of course, just moving the rabbit over here to this. And then put the ship in the ship pile. And then we change the rule on the child after he gets really good at that. And we say, okay, now I want you to play the color game. And put the red over here and the blue over here. And young children can often repeat the new rule, but they can't shift dimensions very well at all. They just can't. 3-year-olds cannot do this. As children get older, you see them getting better, but those that lag behind often have difficulty behaviorally in a variety of ways. And so this is an example of an executive functioning, this ability to shift rules when asked to do so. And so here are our data, and what you see before the shift, non-foster children, that 7 is as good as you can do on this. And so children are everybody's doing really well. The non-foster kids are doing well. The foster DEF and the foster ABC are all doing very well. But then, and so this is when they're asked to put the bunny with the bunny and the ship with the ship. And then you say, okay, shift rules now, and think about what you're going to expect in terms of results. What we get here, as you can see, is we get our low-risk kids and our ABC kids making the shift, but the kids in the DEF foster group not doing it. They're not able to make this shift. And so you see a really very striking difference in executive functioning outcomes related to the intervention. This is several years after the intervention. And in addition to these outcomes among children, Kristen Bernard, who was a graduate student in our lab, looked at mothers' brain activity. She hooked moms up to electrodes. These are high-risk moms that we had intervened with them when their babies were, babies, and the children now are 5 years old. So we're talking 3.5 years after the intervention. She recorded records brain activity when they view pictures of neutral, laughing, or crying faces of babies. Now, what we knew from previous research is that neglecting mom's brain activity didn't differentiate a crying face, a laughing face, a neutral face, but a non-neglecting mom's brain activity did. And what Kristen Bernard found is that mothers in the ABC intervention differentiated the faces, whereas DEF moms did not. And ABC more closely looked like low-risk children. So that's all to say that the intervention seemed to lead, or did lead, to neglecting mom's brain activity changing even several years after the intervention. And so the children's faces elicited different things from moms several years after the intervention. So we've got effects of the intervention on attachment, cortisol, executive function, emotion expression, brain activity of moms. So we've got, I think, strong evidence that this intervention is effective. And now that it's effective, it's important to figure out how to disseminate. And we know from figures nationally, and then from our own experience, our own mistakes early on, that interventions are often not implemented effectively in the community. I'd like for you to think of the issues that might be problematic in your own setting. Some of the things that we ran into was sometimes agencies wanted people to learn new intervention, but they put it on top of an already demanding job with no free time. And so examples where a parent clinician already had an absolutely full 40, 50 hours of work, and then they were expected to learn the intervention. Second, sometimes we were asked to train parent or clinicians who weren't great candidates. For example, they may not have had clinical skills of being able to walk into a home and be comfortable. They might not have believed in picking up a crying baby. But then I think the most important thing is where we were not doing things well, and that is we hadn't carefully developed a system for monitoring whether people were implementing the intervention as intended, or fidelity assessment. So you may think of fidelity as a checklist lots of times, that you're going to check off whether you're doing the components. But that's not the way that it's coming to be defined by the National Institute of Health, and it's not what we were thinking mattered. It didn't matter so much whether a parent coach covered something in the manual. What mattered was, we thought, whether they were making these in-the-moment comments or not. So I want to take you through the couple of steps in disseminating. First, it's critical that you identify what you want to change, and we wanted parent behaviors to change. That's what we knew, that we needed parents to become nurturing and to follow the lead and not be frightening. You know what those are at this point, and that was the easiest for us because we had developed the intervention carefully at that point. But second, we thought, how are we going to get to that point? How are we going to help parents do that? And so we identified what we thought were the key home visitor behaviors. And as I've mentioned, we thought that was these in-the-moment comments. But that took us some time to figure out how to affect that change. And third, we quantified what parents were doing and what parent coaches were doing. And we got stuck here for a while, and I want to go through how we got stuck with this. So we developed a system. So we first became aware we want people to make in-the-moment comments, and where you think of how you do clinical work usually, and that is you watch and you say, well, you're not doing it enough, or you need to do it more, or whatever, and we were operating at that level. And then we became aware that we really wanted to quantify this. We wanted to, because we're a bunch of scientists and because we were frustrated that even people in our own lab weren't making the progress that we expected. So we quantified this, and we looked for where we expected to see comments. We developed a system for coding those comments at a micro-analytic level. ever if you did the entire 60-minute session. But what we found is you could take 5 minutes and code that, and you could get that behavior that really reflected what was happening across the entire 60 minutes. And so what we did is we realized that we wanted parent coaches to make comments at least half of the time that they had the opportunity to do so. And every opportunity for following the lead or for nurturance was a trigger for a comment. And we expect to see, again, 50% of those. And so across the 60-minute session, that's 100 times that we could see comments. And again, half of those we'd expect to see more than 50 comments across the hour. And we wanted to specify then what was going to be in a comment. We didn't just want to comment on that. We got increasingly more precise about what we wanted. We wanted parent coaches to comment on one of the three following components. They could describe the behavior clearly so that the parent knows what is being referred to. And this, for example, would be, he handed you that and you took it right from him. That's a great description of following the child's lead. Or he fell down and looked up at you and you reached right over and patted him on the back. That would be another great example of describing the behavior. They could identify the intervention target of, that's such a great example of following his lead. That's such a great example of nurturance. And, or they could link it to a child outcome. And, for example, when you pick him up like that, he knows you'll be there for him when he needs you. Or when you follow his lead like that, he knows he has an effect on the world. So we link it to a child outcome. Now, at first, we just shared these data, and you can hear we're coding 5 minutes of this, and so we shared these data with parent coaches each week. And so we're making progress towards getting people to do this more, but we're still not there. What we found at this point is that the more parent coaches made in-the-moment comments, the more change we saw in parent sensitivity. So we had real confidence that it mattered, but we still had parent coaches resisting. We had parent coaches that felt awkward making comments, or they felt like they were going to insult the parent or whatever, and we just needed people to kind of jump in. We needed parent coaches to make the comments even though they felt awkward. So like their own overriding. And so what we did at this point is that we trained parent coaches to code their own videos. And this was really the breakthrough for us, because parent coaches each week now, we have them code their 5 minutes of their own video at this microanalytic level. It takes about a half an hour to code 5 minutes. And we have a supervisor here code that 5 minutes. And then we look at the correspondence between the two ratings, but we also can give feedback at a very microanalytic level. And this was the breakthrough for us, this is where even resistant parent coaches start making in-the-moment comments once they become, I think, great critics of themselves. They're coding as they go, sort of. And so what this system then allows us to do is a number of things. It allows us to monitor whether parent coaches are implementing the system. It allows us to provide feedback at a quantitative level. We used to say, you're not really doing enough of this, and now we can say, you're making comments 40% of the time. That's great. That's such an improvement over where you were a week ago. We still want you to get up to 50%. It allows us to evaluate progress over time, and it allows us to establish a point at which we say our parent coaches have reached our criterion. And with that, we expect on target at least 80% of the time, and we expect them to make at least 50% of the possible comments and so forth. And also, there's greater specificity to the system. Things like we don't expect negative comments in the first couple of sessions, and over time, we expect more scaffolding or shaping comments that places, North Carolina and New Orleans and Hawaii and Kansas and a variety of places. And it allows us to know the extent to which people are implementing with fidelity. And what I would say that is, for me, fairly hard to believe, but is that we are now at a point where 80 to 90% of our parent coaches are reaching criterion, whereas before we had the system and before we had other things in place as well, we had maybe 20% of parent coaches doing what we wanted to do at the end of a year. So it's a pretty dramatic and very successful system for parent coaches reaching fidelity. So I am ready now to open it up to questions again.
Okay, that's terrific. Thanks, Mary. So we had one clarification question, which I'll ask first. On the slide where you show, I think it was slide number 27, where you were showing the organization, disorganization statistics in the bar graph. The question is, could you clarify the ages of the children? Were these infants?
Yes, this was the first slide of the attachment.
Yeah, of the bar graph. Right, the
yes,
32% disorganization.
Yes, those are babies. Those are 12 to 30 months of age in that, I think is the range at that point. The next slide of the toddlers are 2.5 to 3.5-year-olds.
Thank you. And then there were a few questions asking if you could elaborate a little bit on what the DEF intervention was and whether there is a comparable intervention that is in use now that people would recognize.
Yeah, it is, it's not intended to be it's an intervention that is most like Craig Ramey's intervention, the Abecedarian project, but what it leaves out are the sensitivity issues that are covered in the Abecedarian, the Perry project, Perry preschool project. So that's what it's most similar to. But it's a critical omission.
Okay, and then there was a question about the parent coaches. Are they paraprofessionals or are they child development specialists?
Every place has their own definition, so it's really different. But I would say mostly who we have worked with is people who consider themselves clinicians or social workers or whatever in a system. So it's mostly not, say, high school graduates. It's mostly college graduates or MSWs, people who are implementing evidence-based practice in other kinds of other types of evidence-based practice. I've got examples where it's not somebody with a college education, and I don't think education is key, but I do think I think that it's got to be people with a I think we've had some trouble articulating it on the basis of degree, to be honest. What we do have now that we're very successful in using is a screening instrument. And what we do in our screening instrument is that we show vignettes in which a parent coach has made comments, and then we show vignettes in which a parent coach has not made comments, and we say, we want you to make comments. And we screen on the basis of this. We code that as on a 1 to 5 scale, and we only accept people who are in the, say, the higher, the 3, 4, 5, the higher region of that. But what we find is that it still predicts how well somebody's going to do in implementing the intervention. So that skill is really important. Now, what's that skill come from? It doesn't come from a degree. It doesn't come from, intelligence, but I'm not sure what it comes from, but it predicts extremely well. We use that with everybody where we, if intervention, we would say we'd really like to be able to screen anybody you've got that you would want to train. We don't want to just train people who haven't passed our screener. So that's a very convoluted answer to that question.
Well, thank you. And we have another question, which is about, are there training modules that are specifically relevant to parents who are adopting children from abroad or who are adopting children in the U.S. but who have inadequate early parenting experience prior to the adoption?
We adapted this intervention. We have a randomized clinical trial underway right now, which I haven't talked about, but with children adopting internationally, and we also use it with parents adopting domestically. And it's not that different from the intervention that I've told you about. What we have incorporated in that on an as-needed basis is given that there are sometimes problems with quasi-autistic symptoms, very rarely, but among children adopted internationally, sort of a rocking things, for example. We have a component that addresses quasi-autistic symptoms and a component that addresses indiscriminate friendliness, which is those behaviors that children sometimes show. They're more likely to show them if they're adopted internationally, where children treat a stranger as if it's a familiar adult. They may just climb on the lap or, not pay attention to normal sort of maintaining distance issues. And so we actually have incorporated that component in all our interventions. Our parent coaches are now a little bit boring. We try to be boring to children, and we've brought this into all of our interventions. And our reason for that, it's clear with children that are indiscriminately sociable why you would want to be boring and not engage the child. And we take, very specific steps with children adopted internationally. But it's also the case that it's easy to become the most interesting adult when you arrive with a bag of toys. And we don't want to be the most interesting adult. We want the parent to be the most interesting adult. And so we've really become very disciplined about not being a great babysitter when we arrive, or a very interactive adult. And we don't engage, some interventions will have the parent coach or the clinician say to the child or speak for the child. We don't do that. We speak directly to the parent only, and are sort of not weird in terms of not talking to the child, but really are not very interactive with the child. And other than that, the intervention is very similar. The quasi-autistic symptoms and the indiscriminate friendliness are different, but the rest of the intervention is very similar, but tailored along the way for children adopted internationally.
Okay, thank you. You mentioned that a number of referrals come through Child Protective Services. Do you find that there's any problem with attrition, either for the parents that are more or less compelled to treatment and those who are coming to treatment on their own?
Well, we don't have, I think two things. One is we work very hard to complete cases even when parents aren't home. So we'll go 3 times if needed for session 1 and 2 and so forth. So that's one thing. It's implemented in the home, and so we'll go until it fits a parent's schedule. It's certainly different, but this is not an intervention that very often people are going to say, I need it and I want to seek that out. Usually it's going to be a referred population that one's going to get. So that's who I know best is parents. Every once in a while we get self-referred, but usually it's at suggestion of Child Protective Services or the child's worker or somebody like that.
And the parents really do complete all 10 sessions as a rule?
Yes, that's more, I could say that's more our doing or the clinician's doing than anybody else. In our Hawaii sample, I think we had probably 2/3 of the families complete all 10 sessions, and that was not a randomized trial. They weren't paying those parents, etc. But that's pretty good. But
okay, great, thank you. And then we have one question. I know you have a resource slide coming up, but this questioner wants to know if you have suggestions about articles or books that they could read that would assist in understanding the attachment dynamics that are regulating to a child.
I can think about that. So it sounds like how attachment serves to help a child regulate. Yes, I can come up with, I think, one really nice article from 1994 is by Jude Cassidy in Child Development, and she really looked at attachment as and how it helped a child regulate. I think also probably the Handbook of Attachment, if one wants to look for a text, that's a really, that would be a good place to go. And some years, I'm sure there are more recent things, but I don't know that it matters. Robert Cairns wrote a book that was more for I think any audience, from a professional to a lay audience, on attachment, that was very useful.
Okay, thank you. And then another question, how does an agency therapist get trained in your ABC model?
You can contact our lab. We don't have a big infrastructure at this point. We need to grow a bit, but we do training, I don't know, 4 times a year or so here in Delaware, and we travel some to other places when there's larger groups that need to be trained. Now, what our constraints are is that, as you can hear, we supervise across an entire year. We supervise weekly across a year, and we do that through Skype. But that puts constraints on us in terms of being able to, unless we were much larger, being able to meet a large need. But to this point, we've been able to keep up pretty well with demand. So what I would say is contact us, or you could just email me or go to our website is the more direct place, and get in touch that way.
Okay, thank you. And I'll just mention that as we move past this questions slide, you actually do list some resources, and the final slide does include contact information for your lab.
Is that okay if I go ahead forward with that? Yeah.
Yes.
Okay.
Do you want to say a word or two about the references you listed?
The references, you mean, or the back here?
The acknowledgments, right?
The acknowledgments, yes. I have been very well supported, as you mentioned, by NIMH to conduct these randomized clinical trials. And Delaware DFS, who I'm working with now, and Philadelphia DHS have been so open and available for working with us over the years. And I've gotten foundation support from Edna Bennett Pierce, and then I've had many people in our lab that have done the hard work of this over time. I acknowledge.
Okay, thank you. And then there is Mary's contact information for those of you who want to be in touch about possible training. So Mary, thank you so much for speaking with us today, and thanks to all of our participants and for all of the great questions you forwarded to us. If you're interested in an encore presentation, or you have colleagues who missed today's webinar, there will be an audio recording and slides on our website within the next 2 weeks. And of course, once you're on our website, you can look at our previous webinars and other informative online tutorials and publications. Our website is www.aia.berkeley.edu. We greatly value and very seriously consider the feedback of everyone who participates in these teleconferences. The link for a brief online evaluation form will appear on your screen in a moment. please take a few minutes now to complete the form, and it will automatically be sent back to us. And we do like getting individual feedback from every participant, including those who may have been listening as a group. So if you are in a group, please make sure that every member gets the link, and we would welcome all of your individual comments. Also on that screen, you will find a link for those of you who are seeking continuing education units. Looking ahead, I just want to mention that Dr. Carla Elio will be presenting at our next webinar, which is scheduled for Thursday, April 3rd. Her talk is entitled Empowering Children in Families Impacted by Substance Abuse, Mental Illness, and HIV/AIDS. And I also want to mention that our center is sponsoring a national symposium in Seattle from June 30th through July 2nd. The symposium's focus is supporting children of parents affected by co-occurring disorders. We invite those of you who are interested to attend, and again, we encourage you to visit our website to register. Space is still available, and our website is aia.berkeley.edu. Okay, thank you, everybody, and we hope you'll join us at our next webinar on April the 3rd. Until then, we wish you all the best.